third Navi podcast. I am your host, Dr. Deepthi Gupta. I am Associate Professor in the Department of Burns, Plastic and Maxillofacial Surgery at Safdarjung Hospital, New Delhi. Today I am with the very dynamic Dr. Sujata Sarabhai, who is the Head of Department of Burns, Plastic and Maxillofacial Surgery at Safdarjung Hospital, New Delhi. And Madam is also the President-elect of National Academy of Burns, India. She is an excellent academician and has authored several books on burns and wound care. Principles and practice of burn care is widely read and loved by students all over India. Apart from burns, Madam has an active interest in cleft and aesthetic surgeries. Welcome, ma'am, to this Navi podcast.
Thank you, Deepthi, and namaskar to all the Navi members. And I thank Navi for giving me this platform, the podcast, to share my views and my experiences with tissue expansion, which will be discussed in the journal today. So, let's start.
Ma'am has an extensive experience with tissue expansion in plastic surgery, and she'll be sharing valuable insights on this article on tissue expansion in burn sequelae repair from Hospital Santa Teresa, Brazil, which was published in the journal Burns in the year 2007. Burns result in a multiple functional, emotional, and aesthetic sequelae, and tissue expansion has been widely used in management of burn scars, and it provides many advantages by providing skin of the same texture, color, and similar sensations and adnexia. It can also be used to expand the graft donor sites. Ma'am, what is your opinion on the role of tissue expansion in plastic surgery?
Diti, I feel that tissue expander and tissue expansion procedure is one of the greatest innovations of the 21st century. And in fact, now it is a very widely used and well documented procedure, and it's a very important tool in the armamentarium of a plastic surgeon when we have to reconstruct various defects and deformities. So I believe that everybody should know how to use this tool to give good results as a plastic surgeon.
Right. So here the authors have used tissue expansion for management of post-burn scars. Are there any other indications apart from scars for which tissue expansion can be used?
Yeah, the scars can be either due to burns or even for post-traumatic scars. Apart from scars, I feel that it has a very good use in removal of the giant hairy nevus, which otherwise, before the expanders were available, we were just excising and putting grafts, which could be either full thickness or split thickness. But now with the expanders, it is a very good modality to replace that hairy nevus with the normal skin. Also, it can be used in case of Romberg's disease. It can be used to prefabricate free flaps. We can expand skin and get large quantities of full thickness graft rather than giving another donor deformity when you're taking a large full thickness graft. So there are many varied uses. Also in aesthetic surgery, we can use it for breast reconstruction before we put the implant. So it's got a variety of uses.
The authors described their experience of tissue expansion over 20 years in 23 patients, of which 14 were female and 9 were male. The youngest patient was 5 years old and the oldest was 48. They have used a smooth surface expander with a remote wall by Silhouette. They will go on to describe their surgical technique, and the first and foremost is to determine the size and the shape of expander to be used. So ma'am, I would like to know that what are the common shapes of expander available in the market these days, and which is commonly used?
There are a lot of different shapes like spherical. Then there's a rectangular shape, which is actually when you inflate it, it becomes a cuboid. Then croissant shape and crescentic shape. So out of all these shapes, I would feel that the rectangular or the cuboidal expander is the one which is most widely and most commonly used, because the surface area gain by using a cuboidal expander is much more versus a spherical expander. It's about 38% and 28%. So we use it more commonly.
And then how do we decide on the size of the expander to be used?
There are various ways of estimating the size. People have brought out computer programs to find out what size and volume of expander can be used. There are various mathematical calculations. There's a very good paper by Dr. Bhandari wherein he has told about how to calculate the size for a spherical expander. But there are no such, there's nothing in literature regarding a rectangular expander. So when we use a rectangular or a intradural expander, the length of the expander should be equal to the length of the defect. The width of the expander, what we use, is either equal to the width or it is slightly smaller. And again, it depends upon the availability of the surrounding skin, because at times you may not have a very wide normal area available. So you will have to use a smaller width. Then there are some articles which say that you can use even width as much as 2.5 times the width of the defect. But by and large, we use it as equal to the width or slightly less than that. And the most important dimension is the height, because it is the height of the expander anteriorly and posterior walls which is actually going to be advanced. So 2 times of that height is what is going to be advanced, but then because of retraction of the expanded skin, which we take as 30%, we take the height of the expander to be about 2/3 the width of the defect. So that's a rough estimate of how we calculate the size of the expander.
Right. So for expanded insertion, the incision has to be given at the border of the healthy area with that of the area to be resurfaced. Then you have to create an adequate enough pocket for the expander to be inserted. Have to achieve hemostasis, and drains are always to be introduced. Now, regarding the plane, the authors have used it in the subgaleal, subcutaneous, submuscular, and subfacial plane. So, how do we determine which plane the expander has to be put inside?
See, most commonly in the scalp, it has to be put in the subgaleal plane. That's the easiest plane to put and get a good expansion. In the neck and in the face, it is the supraplatysmal or the supraisthmus plane, and rest of the body, it is the subcutaneous plane where it is placed. Under the muscle, it is rarely put unless and until you want to raise a musculocutaneous flap as a free flap, then you can put it. But otherwise, the subcutaneous plane is the best plane for extremities, abdomen, chest.
And do you also inflate the expander intraoperatively?
Yeah, that needs to be done. That is important because we are creating a dead space. We dissect till about a centimeter or 2 centimeters around the actual size of the expander. So we are creating a dead space. So it is very important that we inflate the expander to kind of eliminate that dead space. Apart from that, we put a drain also. And secondly, we have to make sure that the walls don't stick together. So we put about 10% of the volume as the initial. Yeah.
Now the authors start the inflation of the expander on the 14th postoperative day. They do it weekly, and they inject saline with either a 21 or a 23 gauge needle. They assess for expansion, and the parameter is the patient discomfort. So here I would like to ask you that how often do you inflate the expander, and when do you start?
I usually start injecting saline 2 weeks after the stitch removal, because by that time the stitch line is quite firm. And usually we do it once a week, but we have done a study wherein we injected it twice a week, and it did give a faster, earlier expansion was achieved. So, but depending on where the patient is staying, how far from the hospital, how frequently he or she can come, we usually tend to do it once a week. And we use a 24 gauge needle because I use as thin a needle as possible so that the port is not, because we are picking it so many times, there should be no leakage from the port.
What is your endpoint for expansion in that particular setting?
Endpoint is initially see the patient's tolerance is less. So the patient will probably say that she's feeling pain. So the first instance the patient says that she's starting to feel pain, you should stop. In the scalp, generally that is what is seen, but in the rest of the body where it is non-hairy, as soon as the blanching starts, that's the point of time when you should stop injecting.
So after the expansion, the authors assess for completion when there are no further expansion gains, or the expander is expanded to twice the area to be resurfaced. And for the expander removal, they would first determine the completion of the expansion, and then either they would advance or transpose the flaps. Do you give some kind of a gap between completion of the expansion and the second stage of surgery for expander removal?
Yeah, we wait for at least 2 to 3 weeks to allow the expanded skin to settle for that time, so that the amount of retraction is less.
The authors have done a total of 54 expansions in 23 patients, of which 50 were completed. 4 cases had major complications in which the expander had to be removed before the completion of expansion. The primary expansion was done in 42 cases and re-expansion was performed in 12 cases. A single expander was used in 36 patients, whereas more than one expander for a single injury was done in 3 patients, and multiple expanders for different injuries in the same patient was done in 15 patients. The lesions were removed by either an advancement flap in 44 patients or a transposition flap in 6 patients. Head and neck was the most commonly treated area. The authors then go on to show their different results. The first is a child in which a 400 centimeter cubic expander was used for a post-burn hypertrophy scar on the chin. The expander was placed in the subcutaneous plane in the neck. They have shown a long-term result for the same patient. Another is a female with post-burn scars on the upper abdomen and bilateral thighs, for which they have used multiple expanders in the same sitting. And third, they have shown a little girl for which they have put an expander in the scalp in the subgaleal plane for a post-burn scar alopecia patch. The authors have also categorized the complications as absolute or relative. The absolute were ones in which they could not complete the expansion and they had to remove the expander earlier. That was, they encountered this in 4 cases. Whereas they also had some relative complications in 9 cases, which were either a seroma or a hematoma or an expanded exposure or a valve exposure, but they were able to complete the expansion in these cases. So, what kind of complications have you encountered in your practice and how do you manage them?
See, initial days when I had started using an expander in a few cases, when we saw that the hemostasis was very good, we came out without a drain. So at that time, the hematoma was very commonly seen. But since then, I always come out with a drain. I never come out without a drain. And so since then, hematoma has never been a complication with expanders. Another rarely seen is that the expander may get infected. That happens infrequently. But if it does get infected, then the expander has to be removed. It's very difficult to salvage an infected expanded space. After that, the exposure of the expander can happen frequently, especially because when the scarred skin starts getting expanded and it gets thinned out, and that is where the expander gets exposed. Or it could be a kinking of the tube, because nowadays the expander which comes has got the tube coming out, the port tube coming out from the side wall rather than from the base. So when it is on the side wall, when we are closing the skin, that might get bent or it might get folded. So that is when the kink happens. Or if it's a long tube for the port, then also the chances of kinking are there. So the tube should not be too long. In case it is kinked, then it has to be re-explored and the kink has to be removed. And then if you're not very careful while injecting and your tube is going over the port, then the tube can also get pricked. So there can be leakage from the tube. Then very rarely again is exposure of the port. And if the port gets exposed, then I don't need to remove the expander. I use it as an external port and I continue with the expansion.
So we have discussed the multiple advantages and indications for tissue expansion. Now, before offering this modality as an option to the patient, we should assess for the mental stability of the patient, the available donor sites, and also the economic feasibility. So I would just like to know that what kind of a counseling do you provide a patient who is being prepared for tissue expansion?
I think the first and foremost thing should be the cost, because expanders are costly. Though now the expanders are being covered under the Ayushman Bharat scheme, so it is good for many of the patients who are under that scheme. They get it free of cost. Otherwise, if they are not, then they have to afford the cost of the expander. And usually we put one expander, but if it's a very large scar which has, or the area which has to be resurfaced, then multiple expanders, 2 or 3 expanders would be better to reduce the number of surgeries. So that is another thing that the patient has to be counseled for, because they have to be ready to go through that phase of 3 months, which the time which it takes to expand completely, that they should be careful that they should not get traumatized, and they should be able to come regularly, at least weekly, for regular expansions, and they should be ready for 2 stages of surgery. Another thing is the patient has to be counseled that though the majority of the scar will be removed, but there still will be a scar in the stitch line, which needs to be addressed post-operatively, and they have to do regular massage or post-operative, whatever protocol we have to do. They should follow that protocol so that the visibility of the scar is minimized.
Similar to other studies in the literature, these authors also had more female patients, and head and neck area was the most commonly involved, and the second they encountered was the lower limbs. And do you also see more female patients coming to you for this surgery?
Yeah, if you see the number of male and female, definitely female patients is much more. But nowadays, even the male patients are coming to us very regularly, especially for the head and neck region, especially for post-burn and post-traumatic alopecia is the most common condition, I would say. And then is the facial scars or scars in the lower part of the face and upper part of the neck, the bearded area, because the males are very bothered about the bearded area not being there. So yes, males are also coming to us very commonly.
The authors have further outlined certain factors that need to be followed to ensure success of this surgery. The size and the choice of expander we have already discussed. The second is the location. Then how do we decide that where to put the expander, and also do we need to put a single or multiple expanders for one particular area?
See, if it's a small scar or a small defect, then maybe only one single expander would do. And placement of the expander would depend on which side of the scar the skin is available. Secondly, the area which is accessible for expansion, because if it's in the cheek, then obviously you can't put it under the eye. You would like to put it below that. And then the area from where, when you advance the flap, your final scar line as far as possible should come along the RSTL line. So I think that is a very important consideration. And for the multiple expanders, I think if it's a big defect, then you can reduce the number of surgeries if you can put 2 or 3 expanders so that you can get enough skin to resurface the defect in one stage. And that generally happens in the either the neck or in the abdomen or in the region of the upper chest.
So the authors further reiterate the importance of a large pocket size to prevent any excessive skin stress or folding of the expander. They also place emphasis on placing the port away from the expander and also away from the scarred region.
So I agree with them. As far as the port is concerned, it should not be too close to the expander, because one, if your tubing is short and once the expander expands, the port can come too close to the expander, so it is possible that you might prick the expander when you are injecting into the port. That is why the port side should be a little away from the expander, so that you minimize the chances of accidentally pricking the expander.
And do you give any other incision for port placement, or you place it in the same pocket?
No, I don't think I have ever used a separate incision. I usually use the same incision to place the port. I dissect through that incision only, and in many cases, in fact, I would put the port in the scar region, so it will be quite away from the expander. And if it is not possible to put it under the scar region, then I would put it at a distant place elsewhere.
Do you also have any experience with an external valve placement?
I have never used an external valve because nowadays many people are preferring, in fact in many places in Egypt and US, they are using the external port, but for our category of patients who come for this surgery, I would not like to use an external port, because you're never very sure about the environment and the surroundings where they stay and whether they'll be able to do it or not. So I generally use it as an internal port.
It is important to assess for the endpoint of expansion at each sitting and appropriately assess the completion of expansion before taking up the patient for expander removal. So I wanted to know at this stage that how much can the expander be inflated?
Any expander I think can be easily inflated to at least twice the volume. Say it's about 100 ml, you can easily go up to 200 ml. Some people have gone beyond that also, even I've done that. So with a good company expanders, generally nothing happens. But I cannot vouch for the Chinese expanders because they might just get exposed or burst or whatever. But otherwise it's quite safe to expand it till twice the volume.
For expander removal, we have to assess for the flap elasticity, and they also give guidelines to how to handle the capsule. So you have to do a dissect around the capsule contour without damaging the vascular pedicle. So, ma'am, what is your preferred method of handling the capsule, and there's a difference between the advancement and the transposition flap?
Yes. If we have to use only the advancement procedure for the expanded flap, then I prefer to do a capsulotomy. That means that only an incision in the capsule is to be given. I never dissect inside that incision line because that would damage the vascularity of the flap. Just give an incision, especially in the leading edge of the advancement flap, because there is the capsule tends to cause a trapdooring kind of thing. So till you release that, your flap will not advance. So capsulotomy incision is given. But if a transposition flap is being done, then I would not like to compromise the base of the flap. So in that case, in the base of the flap, I would not give a capsulotomy incision. I would just transpose it, because then when you are raising a flap as a transposition flap, the movement is quite easy. So you don't need to incise the capsule at all.
And of course, drains are a must in both the stages of the surgery. In concurrence with the existing literature, the authors had a complication rate of 24%, and they also go on to say that re-expansion is possible at an interval of 6 to 12 months, especially in cases where the donor sites are limited. So, ma'am, how many times can an expanded skin be re-expanded?
I think I have used it in a maximum number of 3 times. So the same skin which was expanded, supposing it's a big defect and we cannot resurface it in single stage with a single expander, then we re-expand the expanded skin, and I have done it 3 times. So there have never been any complications.
You have not faced any increased complications with re-expansion?
No, I have not faced any complications. In fact, using the same expander 2 or 3 times also has not given us any complications of infection. We just get it autoclaved or plasma sterilized, and we've never faced any problems with that.
To conclude, that skin expansion constitutes an excellent option in the treatment of burn sequelae, and we have already discussed the advantages of tissue expansion. Now, what I want to know is that how does tissue expansion give us an edge over other modalities such as a grafting or a flap cover?
See, if you see defect resurfacing, as you mentioned, there are 3 modalities. The most commonly used is you excise that scar and you put a graft, which could be a split skin or a full thickness. The donor site deformity is going to be there. If you use a free flap to resurface that defect, then a free flap is going to be a bulky tissue because it's coming from somewhere else in the body. Apart from being bulky, which would require multiple stages of thinning, there is a kind of trapdooring because it's a circumferential scar. So that also will need to be addressed. You really need to thin it in many stages to get a good smooth look. That is where comes the advantage of the tissue expander, because we are using the adjacent skin. So the texture of the skin, the pliability, the color, everything is the same. And we are not giving any extra scars to the patient. We are working in the adjacent areas only, and we are moving tissue from that area to this area. Apart from the incision line, I don't think we give any extra scars. So I think it definitely has an edge over many other modalities of treatment which we just mentioned.
And before we end this podcast, I would like you to give any tips and tricks to our young plastic surgeons for succeeding in this surgery of tissue expansion.
I would like to tell especially the beginners that to gain confidence in using tissue expansion, one should start with using it for the scalp, because that is one of the easiest areas where you can dissect and place the expander, and it has minimum complications. And following that, you can use it in other areas of the body. Start with small defects wherein you can use only a single expander and you can just simple advance the skin. And then you can go on to the other larger defects and other complicated things like, removing a hairy nevus. Hairy nevus on the face, region of the face can be complicated because a single expander may not help. You may have to use 2 expanders, and simple advancement may not help. So you may have to use a transposition or a rotation flap. So before you go in for these complicated flap movements, one should go in for simple advancement procedures, and then maybe the abdomen and the upper part of the chest. So these are the areas. As for the limbs, the upper limbs are the more visible areas. So yes, doing it in the upper limbs can have its own complications because patient needs to be more careful, because it's a mobile and continuously moving area of the body, coming in touch with different other the environmental objects and everything. So trauma can be a problem. Then in the lower limb, it should not be used initially. One should use it in the head and neck region and in the abdominal region before you go on to the limbs. Lower limb, again, the patient's, the safety concerns are there. The patient has to be very careful because they'll be sitting or lying down, so there'll be pressure on the expander all the time. So one should start with the head and neck and these areas before one moves on to the extremities. And yes, and taking proper aseptic precautions while you are inflating, you're putting in the expander and you're injecting it every week. So in all those stages, one has to take proper aseptic precautions, like any implant. If you're putting a breast implant or any implant in the face, you have to take aseptic precautions. The same is true for the expander also. So then the risk of complications, infection and all will be much less.
Thank you, ma'am, for your very valuable insights, and it has definitely enhanced our knowledge of tissue expansion.
Thank you for having me, Deepti, and we look forward to having many more podcasts like this which can improve the knowledge of our younger plastic surgeons. Thanks a lot.
With this, we come to the end of our podcast, and kindly share and subscribe if you have liked this and would like to continue to listen to such educational podcasts in the future. And thank you to our listeners for their valuable time.